We'll now turn to Dr. Pham, who leads the Institute for Exceptional Care, which is a nonprofit committed to making healthcare safe and inclusive for people with intellectual and or developmental disabilities. So Dr. Pham?
Thanks so much, and thanks for having me in this really rich conversation. So I confess that another part of my previous life was actually working for insurers, public insurers and private insurers. And so I think my job today is to give you a sense of what this problem should look like from their perspective and paths forward for payers. And I guess I would begin by saying that to understand payers, you have to understand the levers that they can pull in the system, right? If we're talking about improving the system. They have several core functions. They direct the financing and payment for services. They can motivate clinicians who are in the networks of the health plan products that they sell, whether that's Medicare or a commercial insurance health plan. They can engage and influence because they are large corporations and they are considered thought leaders when they want to take that role. And then they themselves have programs that they run within their health plan products, whether that's a care coordination program or a patient education program. They have programs, and so they have resources and channels for influencing what happens in the system. With all of those levers, though, I am with many of those who have spoken earlier today, which is that the first step in making true change in any endeavor is really internal work and cultural work. And I think that's where payers have to begin, just as it's where clinicians and researchers have to begin as well. And I would point to several action steps that I think they can take. One, I think they need to understand the woeful state of their data. It's not just about collecting race and ethnicity data or data on central nervous system disorders. It's also collecting data on the experiences of care and the actual delivery of care. Payers don't usually go looking for a very granular view of that, but that's not a law of nature. That's just how things have always been done. And I think that there are ways that they can do that. For example, combining that with the lever of setting up programs of their own. I don't know why there isn't a kind of story bank or hotline number that a person, a patient, a family can call when they have a negative experience, and just have it recorded, whatever information they want to share. It is not about being scientific and meeting that standard. It is about having a closer view and a more on the ground view of what actually happens with the dollars that an insurer spends. Another thing to think about is that many of these conditions are very poorly documented in the data that payers look at. And that often gives them a very skewed view of the size of the problem, of who's experiencing the problems. So they have a lot of cleanup work to do in just improving their own data and looking for new tools, more creative ways of improving that data. And if it's machine learning, artificial intelligence, I completely agree with one of the previous speakers had mentioned the concern about bias. But I think that doing that, approaching that kind of solution with deliberateness and a whole lot of partnership with communities can help us get there. In terms of allocation of resources, it's important to remember that while adjusting for socioeconomic status or urban-rural location doesn't erase racial ethnic disparities, the reality is that what contributes to racial ethnic disparities is the physically segregated nature of healthcare. Just as we have in education or in housing, there's physical segregation of healthcare. So for example, in Medicare, 80% of Black Medicare beneficiaries receive primary care from only 20% of the PCPs in the country. And so that gives us a sense, and those PCPs, not coincidentally, have worse payer mixes, they have lower revenues, they have generally less access to resources to serve their communities. And that is where payers can really play a role, right? Because if you are directing financing and payment, it is within your power to think about how to reallocate some of that financing and payment to address historical inequities based on this physical segregation of healthcare. And then I think it's also important to think about the important role that payers can play when they put on their thought leadership or influencer hat, because they have tremendous power to empower communities when they want to, and to even empower directly individuals, right? Through coaching, through listening, through the collection of stories, and then amplifying those stories to the right audiences in terms of feedback, in terms of policy influence. But really, to do all of that, it requires that kind of authentic engagement that other speakers have alluded to. At IEC, the way we've learned to describe our work, because we've come to realize that it's just unusual, it's weird for people to see a general healthcare organization, which is what we are. We don't provide direct services, but we're trying to improve healthcare, and we come from within healthcare. Many of us, in fact, come from payers. How we do authentic engagement is we bring together people with disability and their family members, and we bring together healthcare decision makers. And then we help facilitate the conversation where they identify the problems they want to solve together, where they learn how to share space and power within this working environment, and how they actually solve the problem, with the expectation and kind of setting the group norm that you're just going to, this is just how you work. This is not an aberration. This is actually how you leverage that genius, what we would call the genius of lived experience. And we explain to the healthcare folks, this is actually the most efficient path to the right answer. So we are trying to help you, healthcare, by solving your problem. And the only way we know how to do that efficiently is to actually begin with the genius of the lived experience. And now that we've been through several cycles of this problem solving, they are coming to understand that it's not theoretical, it's real. And I think that if we can engage payers to develop those muscles and that muscle memory, they too will discover new ways of exerting that financial influence, that data influence, that thought leadership influence to help us get to equity.
Thank you, Dr. Pham. Really powerful recommendations for payers. Looking forward to the discussion in just a bit.